So welcome back to Prosper. This is our third module in a 6-sequence 1-hour series, yeah, that's, I think, correct English. So this is Prosper, the proactive reduction of suicide in populations via evidence-based research. As usual, we will start with just a quick review of where we were last time, just to sort of bring everyone up to speed and refresh your memory. Again, these are our references. Here are our learning objectives. So we talked last time quite a bit about the suicidal mode, and that was new information for many of you. It is still new information in the field. Many people are not quite aware of it. So again, we don't usually say active suicidal thoughts or passive suicidal thoughts anymore. Doesn't really have as much meaning with regard to helping us understand what decisions we need to make based on active or passive, but we can better understand what decisions we need to make clinically in terms of disposition and so forth when we talk about the suicidal mode being on or off. So remember, we all have predispositions for suicide and certainly triggers. And while these are important to be aware of, we don't need to dive deeply into them. We don't need to ask a lot about them. It's interesting. Many clinicians sort of get caught up in a 15 to 30-minute conversation with patients about why they're suicidal, and that's actually less. It's less critical to understand that. It is certainly important to have some context, but how they got this way, what's going on in their life that led to this, is actually not as critical as understanding what are they experiencing right now in terms of thoughts, behaviors, feelings, and physiological events. And so if today is Tuesday and I see a patient today who made their appointment yesterday, and the patient says, well, I called the clinic yesterday because I had thoughts of killing myself. And so I say, well, are you thinking about that right now? They say no. So in other words, the suicidal mode was turned on yesterday, but it's not on right now. There are other patients for whom we might speak to, and they say, well, it was on yesterday, and then it turned on again as I was driving here. I was thinking about it. Or, yes, right now I am thinking of killing myself, and that's why I'm so glad I'm seeing you, Dr. Corso. So we talk about the suicidal mode being on or off and when it was on or off. As we'll discuss later today, we will take a frequency and duration of that, right? So we'll want to know, has it happened once a day over the last month? Did it just happen once over the last month? And how long did it last? 10 minutes, 2 seconds, right? So these are really important for us to be able to recognize when the suicidal mode is on, because if it is on, our job is actually to turn it off. Okay, we don't want patients leaving our clinics before we turn it off. Questions about the suicidal mode? Okay, and if you remember, we saw a video of Sinead O'Connor, who she put it on YouTube. Oh, go ahead. Is there a question? Hot mic, hot mic.
What were you saying you might go like that? Hey, I don't know, do y'all like it? Yeah. What are you gonna do?
Kim, if you wouldn't mind muting the hot mic, you can do that as the host. That'd be great. Thank you.
No, I'll get it. I'll take it, but I'll bring it back.
Okay, so if there are no questions about the suicidal mode, we'll just move on. We also talked about standardizing suicidal language. So especially when we're working in, let's say, a patient-centered medical home, where we have multiple types of professionals who frankly come from different disciplines, have different lexicons that they use within their specific discipline or license area of expertise. We want to make sure we have shared language that means the same thing to each other. So when we're communicating about a patient in a very team-oriented fashion, we are able to understand exactly what each of us is communicating. And when we say exactly, we don't only mean what is happening with this patient, but rather what are the implications of what one of us just said. So we avoid these phrases because frankly, they are judgmental, they're value-laden, they don't really appear in the literature. They don't tell us that, okay, when there's a gesture, the research says do A. When there's a threat, the research says do B. It's not really a thing, if I can use that phrase. And many times what these terms do as a team, if Kim and I are consulting about a patient, if I say, well, what happened with that patient? And she says, oh, it was just a suicide gesture. then that kind of statement essentially authorizes the status quo. It essentially communicates between us that we should do nothing different with regard to treatment or evaluation, that we're just going to stay the course. And so from a social perspective, it has the unintended effect of leading people to not make different treatment decisions, okay? Instead of these words, and for just, again, to put a point on this, commit suicide, when we talk to people who have survived attempts and people who have lost a loved one to suicide, they say that when they hear the word commit suicide, it's there are two things we commit, and those are sins and crimes. And so if I'm experiencing suicidal thoughts, I'm not going to tell someone I'm thinking of committing suicide. Just that word becomes, it's stigma laden and is a deterrent for me to reach out for help from someone else. So if we all get into the habit of eliminating that word and using the words died by suicide, killed himself, ended her life, really just telling it for what it is, that it does not stigmatize it as much, and actually makes people who are struggling with suicidal thoughts much more likely to be able to share. Now, we also have these terms that we went over in detail: suicidal ideation versus death ideation. So non-suicidal morbid ideation, non-lethal morbid ideation, death ideation. These are three synonymous words or terms. I like death ideation and suicidal ideation, SI and DI, because it's easier. It's less, they are less syllables. Then we have suicide attempt and non-suicidal self-injury. This is also sometimes called non-lethal self-injury. And again, this is the difference between someone who's cutting, which is explicitly not for the purpose of ending their lives, and as contrasted by suicidal thoughts, which are explicitly intended to help someone escape their pain and end their life. So can someone read this for us? We went over this very briefly, and then I think we started it and then skipped it. Can someone read this for us?
Sure. I'll go ahead. I got very angry when they kept asking me if I would do it again. They were not interested in my feelings. Life is not such a matter-of-fact thing, and if I was honest, I could not say if I would do it again or not. What was clear to me was that I could not trust any of these doctors enough to really talk openly about myself.
So thank you for that. This is a real patient's statement. We've said on at least each of the last webinars on this topic that part of the goal of Prosper is to teach you how to fish, right? The idea that you hand someone a fish, they eat for a day, you teach them how to fish, they eat for a lifetime, right? There's that old saying, that old phrase. And so clearly the clinician who is being referred to in this example only had a fish, right? They only had a checklist that they were going through, and they were clearly asking, are you going to do it again? Do you think are you going to kill yourself again? It was as if they only knew one way to ask the question or one thing to assess, because that's what was on their template or their form. And instead, what we're going to talk about in the next few minutes is helping you understand how to ask questions in many different formats. Because if you understand how suicide works, then you can recognize it in its different forms, but you can also help be much more patient-centric than clearly this provider was, by knowing how to ask in different ways. So what we're getting into is the work of Dave Jobs at Catholic University. Brilliant suicidologist, has developed this over the last 30 years. His is called CAMS, a Collaborative Assessment and Management of Suicide. It's a super program. Strongly encourage you, if you work in the mental health field and you'd like a great workbook for how to work with patients, that's a good one. If you know someone who's a therapist, it's most appropriate in a psychotherapy setting, but we can extract elements of it for the primary care setting. And so some of these elements are that suicide's a distinct problem. It's not just about depression. It's not just part of a personality disorder called borderline personality. This is where, when we talk about an accurate way of working with patients versus that better safe than sorry or cavalier approach, this is where the rubber meets the road. Is we have to assume and believe and accept that the patient is the expert of their own suicidal experience. So rather than me saying, well, I'm the doctor and here's what I think is happening, we have to defer to the patient. What are you experiencing? And so if we can think about the suicidal mode for a minute, what are your thoughts about suicide? How frequently do they happen? What's the duration? What are your feelings about suicide? What are the physiological events happening when you say, yesterday, when you called the clinic to set an appointment, your suicidal mode was on? What physiologically was happening? What behaviors or activities or actions were you doing, right? So really putting the patient in the driver's seat, and we're really more like a navigator, okay, who understands the roadmap and has the roadmap, but the patient is sort of driving us through that route or that path. We know from this longitudinal research within the CAMS approach that if we ask a patient on a 1 to 5 Likert scale, let's actually use the whiteboard feature here in Zoom so everybody can feel like, you know, we're really getting the full experience. So if we have a 5-point Likert scale, and this is a 5, and this is a 1, and this is very unlikely. This is very likely. And we ask someone, so this would be 2, 3, 4, 5. And when we ask patients, this is what Dave Jobs did. It's a longitudinal study. He asked people who were suicidal, do you think in the future you're very likely to kill yourself? Actually, I believe it's highly likely. Let's turn that into an H. That's a highly likely and a highly unlikely. Do you think you are highly likely to kill yourself or highly unlikely? People who answer a 1 and a 2 over time generally did not attempt. People who answered a 5 did attempt, and to a lesser extent 4s. And then the 3 is sort of a mixed bag. So you can ask your patients about this. Do you think, and on a scale of 1 to 5, do you think, how likely are you to kill yourself at some point? And if they answer 2 or below, you can have confidence that the research says if they answered a 2 or below, they are highly unlikely to kill themselves. Let me hit pause because this is a very important point. There are very few conditions that you can assess and learn a ton about with just 1 or 2 questions. And it's because of the research that's been done on this particular item. So questions or comments about that? Okay, hopefully you're following that.
Would you recommend and or do you do this? Do you draw this on a piece of paper or have a Likert scale when you are meeting with a patient?
I do. I think it's one of the most helpful ways we can empower them to be the expert about their experience and then to share with us so that we can help make decisions collaboratively. So this is, again, this is the collaborative approach that we would favor to a much more paternalistic, maternalistic, parental kind of approach. And we are inherently trying to trust what they tell us, right? And that's why it's so difficult for people to take the accurate approach versus the cavalier or better safe than sorry, is because it requires trust. And it's not true that the majority of suicidal patients are being deceptive. That is not a thing. That is not a research-based finding, okay? There are certainly people whom, if put a yes or no in the chat box for those of you attending, put a yes or no in the chat box if you've ever had a moment working with a suicidal patient where all of a sudden it seems to be like an us and then dynamic, where you are asking more pointed questions or trying to get more details and they become more and more evasive or cagey or sort of evasive is the best word. So put yes or no in the chat box if you've had that experience. Looks like Julie has not, but the rest of you have. So Julie, well done. It must mean you're doing something right, or heads up, it's going to happen at some point, okay? And that's because we are trying most honestly to understand the nature of the problem, but they are concerned that we are going to override their autonomy, okay? They've heard a nightmare story from someone, a friend, a family member whose doctor hospitalized them sort of against their will. They've seen it on TV, what have you. It doesn't, you know, there are tons of ways they could sort of expect this. And so the second that dynamic arises where you feel that us and them, the key point is to call attention to it and say, hey, you know, it seems like what has happened over the last minute or two is the more I am diving deeply into some details, the more uncomfortable you're getting about sharing. Am I onto something here? And what's that about? Okay. It's so important for you to broach that topic with them because it furthers the trust in the relationship. It also should reassure you that they can be trusted. So historically, what we do is when we feel that us and them, we get more heavy-handed and we start asking more pointed questions, and we sort of operate under this hypothesis that, well, you know what, if they're not going to tell me the information, I have to assume the worst. And instead, we should be direct and work with the person to discuss what's happening. Okay. So can't encourage you more or give you more strong, implore you to have that conversation when you detect that divide between you, that disconnect. It's so important to maintaining this accurate collaborative approach. Here are the other messages you want to explicitly or implicitly communicate to patients. Now, it's a little different with children. So for example, we don't ever want to usurp their autonomy. We don't want to sound judgmental or value-laden about the fact that they're suicidal or having suicidal thoughts. For example, when I am working with adults, I say to them at the very beginning, once I realize that they are having suicidal thoughts, I'll say, look, I am crystal clear on the fact that you can deceive me and tell me part of the story and sort of fly under the radar. I get that, I understand that, and it's normal to feel that way because you probably don't want anything to spin out of control. You want to maintain the autonomy over your life and your healthcare. And I respect that, and I'm not interested in getting in the way of that. What I am interested in doing is helping you. And the more forthcoming you are with me, the more it enables me to help you. And so I say that to all the adults when I see them. Now, I don't tell that to children because telling a child, I know you can deceive me and I know you can kill yourself if you want to, almost by the power of suggestion encourages it or authorizes it. Sort of like when we tell a child they're good or bad, they become good or become bad based on that feedback over time. So just a footnote there about children and adolescents with that one. With adolescents, it's obviously a judgment call. If they're a little bit older, they can probably handle it. But we want to communicate that you're the expert, that this is just like any other problem, that I am very confident about not only addressing it, but that help is available and it's going to work, right? So please do try and keep this on hand and do try to implicitly and explicitly communicate these messages. And this is where we continue to be both collaborative, but also to start empowering. So we know that a stronger sense of meaning in life is significantly associated with lower emotional distress, less severe suicidal ideation, and better functioning across academic or occupational areas of life, interpersonal areas of life, emotional functioning, ADLs, all different types of functioning. So when people feel a strong, positive sense of meaning and purpose, they are at lower risk for suicide. And so the more we help them cope and the more we help them address, as we'll see in probably we'll talk about this next time, their reasons for living, then the more we can help maintain and restore that sense of meaning and purpose in life. We know that, and frankly, what that is doing is just the process of helping them learn to cope, because it is a process. It's not a switch. It doesn't turn on and off, okay? It is a learning process of building skills that instead of my mind going from a stressful moment to the suicidal mode turning on, my mind slowing that down so that when something stressful happens, I insert myself into that cycle and say, what do I need to do to calm myself down or to manage this, so that there is active coping versus sort of just reactively tolerating this and allowing these thoughts to come. So it really is teaching people how to assert themselves with healthy coping skills. We know that effective crisis response plans can reduce attempts up to 76%, and we talked about that in the first module. And BCBT, which is brief CBT for suicide, it's a manualized treatment for suicide, can reduce suicidal behavior by 60% compared to treatment as usual. Okay, so when we talk about effective coping, oftentimes when I'm working with mental health providers, specifically behavioral health providers, and I say, well, many of us, raise your hand if you do risk assessment with suicidal patients. Everyone raise their hand. When I say, how do you treat their suicidal symptoms, I seldom get any hands raised. Okay, most mental health providers, and frankly, physicians and NPs and PAs, I've seen the same, and nurses, they're good at doing the assessment part, but once they assess the level of risk, if the risk is mild or moderate, something where they just have to change the meds, they're still going to continue with outpatient care, they shift their attention back to the diagnosis, like depression or anxiety or marital problem or financial problem. And that's where we are not practicing contemporary evidence-based medicine. Contemporary evidence-based medicine would say, okay, now that you know that they are at a mild or moderate risk, or even a high risk, how are we teaching them how to cope with those suicidal thoughts? And in the big picture, folks, what that means is, how are we teaching them to turn off the suicidal mode and to prevent it from coming on in the future? How are we getting them to work upstream so that when a trigger happens or a stressor happens, they immediately, not only have they learned healthy coping skills, but they are in the habit of drawing on those skills and summoning the resilience and the empowerment they have to help themselves. And so that's where we're going with the rest of Prosper. We're not going to focus necessarily on that part of treatment. Oftentimes that treatment's going to happen in a specialty mental health setting. There's nothing wrong with broaching this topic with the patients in primary care, but oftentimes if they are at the moderate level or higher, they probably need to see a therapist and or a psychiatrist. Because it's they can do it's a specialty level of care by that time. So here are the coping skills. The research is pretty clear. We have to teach people how to identify their emotions, label their emotions, and then regulate their emotions. Now, this is derived of at least 2 subcomponents, including tolerating distress. So in a moment of crisis, not reactively jumping to do whatever one does in an effort to just eliminate the uncomfortable feelings. So as we saw in the Sinead O'Connor video last week, she's very agitated, very worked up, a lot of psychomotor agitation. And that uncomfortable feeling of all that arousal and those physiological events, that's what experts think is what drives people to be so impulsive, is tolerating the racing thoughts with the intense negative emotions, with those really uncomfortable physical feelings. It's overwhelming for people. And so distress tolerance skills it comes from the dialectical behavior therapy, DBT literature, highly effective. It's 25-year-old research, teaching people to just not react. So how do you sit with what you're experiencing? It doesn't mean sit with it and focus on it, but just not react in a drastic way, because when people are reacting in those impulsive and drastic ways, judgment tends to lack. Okay. And so aside from that, the emotional regulation skills involves relaxation and mindfulness, also involves adopting healthier or more adaptive ways of thinking. Okay. Because we know that when negative emotions are active and they're intense, it impacts our frontal lobe's ability to make decisions. It impacts our perception. Right? It's that whole glass half empty, glass half full. If I'm in a bad mood, I'm going to see the glass as half empty. We know from a half a century of psychology and neuroscience literature that cognitive states and affective states or emotional states have a reciprocal interaction between one another, right? And if I'm in a very negative mood, I'm less likely to notice things that contradict my mood, and I'm more likely to notice things that, or even paint my experience with that mood. We talked about this, let me see, yeah. The only thing we haven't discussed is the last bullet there, is that suicidality is marked by ambivalence. Ambivalence is the hallmark. It's not a state of indecision. It's not like, well, I don't know if I should go right and choose death or go left and choose life. It's, I want to live, but life is so miserable, so that makes me want to die. I feel both at the same time, okay? And we'll talk about that more next time and the time after, frankly. Ambivalence is a big component. Above all things, please, please, if you don't learn anything from this 6-series webinar and all you learn is one thing, let this be it. Do not talk the person out of killing themselves. This means don't talk them off the ledge. When we do that, it would appear to have a short-term benefit, and I think the intentions are pure. The intentions are, let's talk them out of it so that we can have them calm down and access a higher level of care. The problem is they're not always going to follow up with that care. What happens if it turns back on? And why waste the opportunity to teach them something and help them grow and empower them to manage their own stuff? Why miss that opportunity by putting a Band-Aid on it that's going to overflow anyway? So please, please do not talk them out of it. Now, I'll be honest, many of us don't know what it sounds like when we are talking someone out of it. So consider for a moment, what would, and we'll take sort of 30 seconds of silence, think about what you have said in the past to suicidal patients. What does it sound like when you are talking them out of it? Because if you can't identify those words within your own voice, your own lexicon, you're not going to be able to catch yourself saying them and do something else instead. So take a moment, and if you'd like to share, just throw them in the chat box. What have you said in the past, or have you heard another provider say that is talking someone out of it? Okay, so we've got some great quotes in the chat box. So you don't want to do that, right? You have so much to live for, right? We have that twice. Yeah, that's really invalidating because someone realizes they have a lot to live for, but that it feels like garbage right now. So that's really not helpful. It alienates them. What would your family think? That's awesome. You don't want to do that to your kids, do you? You have kids, right? You know, all of those are very loaded statements that then make the person feel even guilty for thinking of ending their lives. So great job with that in the chat box, guys. We don't want to say any of that. Sometimes one of the most common examples of talking someone out of it is when I start a sentence with the word I. I'd like you to do this. What most of my patients find that when I do that or when we do that, it works. What about if we do that? So these like sort of suggestions like that, or don't you think if we just ... it would improve, right? So those are non-starters, guys. They might temporarily put the risk in abatement, but it doesn't help. You're not really moving forward. You're really just handing that risky patient over to the next person, when what we could do is take that opportunity to build that patient. Okay, I think I've beaten the dead horse. It's laying there. It's lying there, excuse me. All right, so here's a basic risk assessment. Now, if you are a fan of the CSSRS, the Columbia Suicide Severity Rating Scale, when they were developing the Columbia at Columbia University, we were publishing this. So it's both based on the same literature. That just happens to be sort of a standardized instrument. Whether you like a standardized instrument or whether you like more of a visual flow chart, it doesn't matter. It functions the same way. The key here is that you ask the questions in order. So this is by definition and design a triage approach. Particularly in primary care, this is important because of the element of time, which is often lacking, okay? So for example, if we ask the first two questions and they are both negative, so the patient has no suicidal thoughts and they've never had a prior attempt or prior behaviors, We don't have to do anything else. We don't have to ask anything else, okay? So also one footnote about this, and this is the rest of today, we'll go through sort of the first two of these, and then next time we'll go through the remaining three. This is where people often stumble when they start asking about suicide, they end up getting sidetracked into the person's story. I'm not suggesting that a patient's personal story is unimportant, but what I am saying is they'll get sidetracked into a whole line of questioning about, well, how did this start and when did this start and how did you feel and what were you thinking? And, oh, I can't believe your spouse said that to you. That is so mean. And just getting sort of knee deep in all of the why am I suicidal instead of attending to the more proximal variables that help you figure out what's going on and what do I need to do about it. So another way to say that is whether I don't have a job because I got fired, whether I don't have a job because I got laid off, whether I don't have a job because coronavirus hit, whether I don't have a job because the building burned down, at the end of the day, I don't have a job. And so the series of steps I need to take as an individual to get a job are the same, irrespective of those sort of reasons why. And so it's just, I know that this resonates with the primary care community because this is the primary care mindset, is we have to know what's in front of us so that we know what to fix. The etiology is important, but it's not the entire story. It's not the entire picture, right? Oftentimes the etiology tells us what we need to do. So as long as we know someone is suicidal, we don't need to know a lot of the detail about why. We do need to understand the frequency, duration, et cetera, and we'll get to that next time. Questions about what we're about to discuss. We're about to go through a risk assessment procedure. Any questions before we proceed? Okay, super. All right, so let's start with the first skill. The first skill is differentiating suicidal ideation from death ideation. Now, we went over those terms briefly, and they are distinctly different. And so we care about the difference because death ideation is not a reliable predictor or antecedent to subsequent suicidal behaviors, but suicidal ideation is. Okay, that doesn't mean everybody with SI will attempt or engage in suicidal behaviors, but it does mean that it doesn't go from death ideation to a suicide attempt. It doesn't skip suicidal ideation. So death ideation is, remember, this is actually quite common, just thoughts of being overwhelmed. I wish I weren't here. I wish I didn't have to deal with this. Oftentimes it's going to happen when people are either at their limit with regard to their coping skills and resources, sort of the stressors at home and at work or school are piled on top of one another, or it can happen when people didn't have a deep, wide repertoire of coping skills to begin with. So just be aware of that. There are children at age 8 who will say, I wish I were dead. Are they suicidal? No, they're overwhelmed. They have no way to cope with the intense negative emotions they're feeling or the overwhelming life circumstances that they're experiencing. So this is a really important issue to refine your understanding of, to not just think that if someone thinks about dying or wants to die, that means they're suicidal. It actually doesn't. And frankly, they are at a bit of a low risk. We should not be that concerned. Now, of course, we want to address it, but if someone only has death ideation, we're not asking about plans because they're not suicidal. We're not asking about intent because they're not suicidal. We're not considering hospitalization because they're not thinking of killing themselves. So again, back to the triage approach, the first critical piece to discriminate is the person in front of me experiencing suicidal ideation or death ideation? And we talked about this. This is kind of what we've been talking about. Okay, so after each of these skills, I've included what I call a green screen. It's not the thing the weatherman or weatherwoman stands in front of where they project the maps of the weather, but it is all in green font. And the intention is that you print out the green screens and you staple them together, you hang them up by your computer, wherever you practice, so that if you do have a suicidal patient or when you do, you have these at your fingertips. This is 3 different ways of asking the same question. One common pitfall among physicians, NPs, PAs, psychologists, psychiatrists, social work, counselors, the whole 9 yards. When we ask the first question, if the patient balks and they don't really answer it, or they get sidetracked, or they start to cry, we kind of abandon that question and move on to other stuff. Please, please don't do that. Re-engage and ask the question a different way. Make sure you get to the bottom of step 1 before you do anything else, especially before you move on to step 2. So skill 1, are you having thoughts of killing yourself, or are you wishing that you were dead? Another way to ask this is, so it sounds like you've been thinking a lot about your life ending. Do you see yourself playing a role in making your death happen, right? So various different ways to ask the same thing. If you are routinely using either outcome instruments or sort of screening assessment tools, you should know that only the Columbia does differentiate between SI and DI. If you look at the PHQ-9, the BHM-20, all of these instruments, they really ask about death ideation and non-suicidal self-injury. They don't directly discriminate between SI and DI. And so they're not very useful in terms of a clinical decision-making process. Now, again, the Columbia is, and using the process that we're describing in our flow chart is. So let's do a little audience participation exercise in the behavior analysis field. We call this discrimination training. It is not training you on how to be racist or to be sexist. What it is training how to discriminate between two different similar concepts. So discrimination training, in the chat box, put DI or SI, okay? So, and you can put a D and an S if you'd like. Just remember D and S are next to each other on the keyboard. So if you move very quickly, you don't want to make a mistake here, okay? So we're going to go through each example of what a thought is, and your task is to say that's death ideation or suicidal ideation. So the first one, if I am planning my death, is that SI or is that DI? What do you think? And I'll separate each one with a question mark. I'm planning my death, is that SI or DI? Looks like we have 3 people responding, 4 people. Good, we've got everybody. Well done, that's SI, good job. Okay, for the next one, I'm having thoughts of death or dying, SI or DI? Thoughts of death and dying. I'm having thoughts of death and dying, SI or DI? That is DI, well done. I'm wishing I were dead, SI or DI? Wishing I were dead. SI or DI? Looks like we have all DIs. That's great. In a bigger group, it's harder to track all this, but it's a small group. We can get kind of score each one as it goes. Okay, I'm thinking about how I might kill myself. SI or DI? I'm thinking about how I might kill myself. SI or DI? Thinking about how I might kill myself. Okay. So we have a little bit of a mixed bag there. This one is suicidal ideation, even the word might. Remember that when we look at a suicide attempt versus non-lethal self-injury, non-suicidal self-injury, the biggest difference, the only difference between them is when I was engaging in this behavior, did I imagine I might die? Did I think it could kill me? Did I hope it killed me or want it to kill me? So even having it come to mind makes it suicidal versus just death, okay? And in the case of what the action is, it makes it an attempt versus just non-suicidal self-injury. Okay, the next one, thinking of killing myself, SI or DI? Thinking of killing myself. Okay, so we got a mixed bag there, about 50-50. That's suicidal ideation, if I'm thinking of killing. So thinking of dying means I happen to die. Thinking of killing myself means I'm the one playing the role. So that when I'm the one playing that role or being a part of making that happen, that's the more risky one. That's the SI. Okay, next one. I wish I could fall asleep and not wake up. SI or DI? Wishing I could fall asleep and not wake up. It's a little bit of a tricky one. I think you all got it. That's DI, right? So who's to say that falling asleep, whether I fell asleep or whether I put myself to sleep, right? So it depends on what they say. So for some of these, you might have a follow-up question. Wishing I could fall asleep and not wake up, that's DI. but I'd want to ask a follow-up question like, well, do you see yourself doing something that would make you fall asleep or stay asleep? And they say no. Well, then that's only DI. If they say yes, it's SI, right? Imagining I will play a part in causing my death, SI or DI. Okay, well done. We got 100 on that. That's suicidal ideation. Good job, guys. Okay, so now we're going to do this one more time, taking it from concept to actual quotes. I'm giving you a freebie there. I think that's just for fun. I want to sleep and not wake up. Is that SI or DI? I want to sleep and not wake up. SI or DI? Good job. We got 100% there. It's DI. The next one, I just want to end it all. SI or DI? I just want to end it all. This is a little bit tougher. We're going to trip some people up. It looks like we had one DI and the others were SI. This one is SI, right? Because I want to end it all. Now, I think you could say, well, this is just like I want to die. Okay, well, fair point. So we still have to have a follow-up question. Are you the one ending it, right? I want to end it all. Does that mean, should I understand that as I want to be the one ending it, or just that I want this, right? So there's some ambiguity in a statement like this. We've got to tease it out to find out. So anytime you feel like, I'm not quite sure if this is SID or DI, I've just tried to ask a clarifying question, but I'm still unclear. Don't stop clarifying. Understand and discriminate between the SI or DI before doing anything else, because if it's SI, you've got a second set of tasks to go to do. And if it's DI, there are a different set of tasks. What if I stop taking my meds for my chronic condition? Is that SI or DI? What if I stop taking my meds for my chronic condition? Okay, it looks like we have DI. We're missing one person didn't chime in. Oh, there they are. Okay, DI. So that one is most likely aligns with SI. So, and again, if you have doubt, you always want to ask a follow-up question. But this is what we've previously might have said. It's a passive suicide attempt. It's that idea of like, oh, I'm going to drive down that curvy road and take my hands off the wheel and put my life in God's hands. And if I die, then he meant for it to happen, right? And it's like, well, that's a suicide attempt. Okay, that's not, we can't just sort of by abstaining from engaging say that it just happened, right? There's a great, if any of you are fans of the old hard rock band Rush, Canadian band, there's this song called Free Will, and there's a great quote in Free Will: if you choose not to decide, you still have made a choice, right? And so that's a perfect example of this. If I stop taking my meds for which that I need, would it kill me? Yeah, that's a suicidal thought, okay? Killing myself would unburden my family. Killing myself would unburden my family. Looks like so far we have all DIs. Anyone else? Let's see, 1, 2, 3, 4. There we go. We have all of them. So that's SI, okay? Because I'm killing myself. It's not dying. If we said dying would unburden my family, that would be DI. But because they're saying killing myself, it's them playing a role in making their death happen, okay? So we got 100% wrong on that one, and that's okay. And again, if there's any real concern about these, you want to ask follow-up questions. So don't feel like if you get it wrong, that's you'll never get it right. Just ask follow-up questions. What would people say if I died? What would people say if I died? Okay, good. We've got all the answers in. And that one was DI, 100% on that. Well done, guys. Okay. So now, as I often ask, helpful, unhelpful, or neutral? Was that exercise helpful, unhelpful, or neutral? Want to just get your feedback. The goal is to have this be time well spent. Okay. Looks like we have a few H's in the chat box. Good. Okay. Yeah, being able to do this first skill, I can assure you, training hundreds and hundreds, well, probably thousands of people here, going on 1,000 now after COVID. People screw this up all the time, and they will hear death ideation and actually skip right to hospitalizing people. Think about how damaging that is to a person who doesn't believe they're unsafe. And maybe they withdraw a little bit within the appointment because now they feel like they're going to have their control and power taken away and be hospitalized. And so they stop sharing. And then that confirms what the provider thinks. So they hospitalize them, and it was all out of death ideation. They weren't even thinking of killing themselves. This happens all the time. People are hospitalized prematurely all the time. So I can't express more how critical it is to get this first skill right over and over consistently, so that we start off on the right foot and we know what we're working with. It will help prevent that cycle of having people avoid sharing because they have a negative experience from an unnecessary hospitalization. And it also saves the system money, which whether you're a decision maker or not, even if you are part of a hospital system and you stand to gain financially by people being hospitalized, it's not right to hospitalize people when they don't need it. It is wasteful. And I think even the CEO, CFO, COO business persons within our ranks can appreciate that they would and can agree that they'd rather not make money out of waste. They'd rather make money because they're doing something positive. Okay. Yes, it's capitalist system, but we still have ethics and morals. Okay, so skill number 1, tell me in the chat box, what is skill number 1? Differentiate between what and what? Just a little pop quiz. Skill number 1 is to differentiate between, thank you, Sadie. So SI and DI, Harry, death and suicide. Yeah, Julie, SIDI, good. Differentiate between death thoughts and suicidal thoughts, death ideation, suicidal ideation. Good job. I'm going to keep quizzing you as we go. So skill number 2 is assessing for multiple attempt history and for past suicidal behavior. So this is that old idea that the most robust, what people do in the future is what they're doing right now or what they've done in the past, right? Best predictor of future behavior is current or past behavior. Whether there are other risk factors present or not, this remains the most robust predictor. So again, let's try to reiterate this. Whether they're male and own a firearm, whether they're female, whether they're white, whether it's a person, a transgender person, yes, those are all risk factors that are between subjects, between factors research, but someone's personal history of engaging in suicidal behavior, that is a better predictor than any of those other things. So again, this is what we can bet on. We can't look at demographics and just use a checklist to see if it applies to the person. In fact, whether someone is just thinking about it and has never attempted versus someone who's attempted once versus someone who's attempted 2 or more times, those cohorts have a different risk stratification. So true or false, this is a true or false that I'd like you to answer in the chat box. True or false, the vast majority of people who attempt suicide and live will attempt again. True or false, the vast majority of people who attempt suicide and live will attempt again. Okay, let's see if we have everybody's answer. 1, 2, 3, 4, 5. We do. Okay, so the answer is false. Okay, the vast majority of people who attempt suicide and live will never attempt again. In fact, they wake up and they realize they're alive and they say, oh my gosh, thank goodness I'm alive. That was the dumbest thing. That was such a near, maybe I can keep trying for life. That was scary. So the vast majority of people who attempt and live will not attempt again. Okay. This is exactly why when someone does have 2 or more attempts, it's that much more concerning, because not only have they woken up once and still been thinking about it, but then they actually acted on that. Okay. So we know that people with 2 or more attempts are first of all, they're at a chronic moderate level of risk for their whole lives, but they are at a substantially higher level of risk as well. This is, by the way, called the post-attempt response or the post-survival response. What it means is that moment where someone comes to and regains consciousness and realizes they're alive, and they put the pieces together, either, wow, I'm laying on the floor in my house in a pool of vomit and blood and excrement, or hey, I'm here in the hospital and I woke up in the ICU and I'm alive. What's their immediate thought and their immediate feeling? Is it one of sort of like safety, gratitude, I'm glad to be alive, or is it the opposite of sort of frustration, anger, more worthlessness, like, dang it, I'm so worthless, I couldn't even kill myself. Or dang, now I'm going to continue to be a burden on my family, right? So, and we'll talk about the post-survival, post-attempt response next time as well, in terms of using it as a prognostic indicator, a predictive indicator. Let's look at these data in a slightly different format. Here's the baseline level of risk, and also you could use the word distress, right? So someone's baseline is here. When an acute crisis occurs, this person who's never attempted, there's this parabolic curve, right? They're going to increase, and then eventually their risk and their distress will peak, and it'll resolve back to baseline. With your multiple attempters, their risk is so much higher at baseline, and their distress is often higher. And so when they increase, it takes a lot longer for them to settle back down, both in terms of risk and in terms of distress. This is a distinct animal, okay, guys? This is as distinct as the 10% of people who, when they see their own blood, their blood pressure actually drops, right? The prevalence of blood phobia in our population is 10%. Most of us, when we see our own blood, there isn't that reaction of a drop in blood pressure, but for 10% there are, right? There's also a 10% group of us where the right and left hemisphere have cross functions, right? What's supposed to happen on the right side actually happens on the left, and vice versa, right? So similarly, there's a small percentage of our population where there are multiple attempters. Now, I don't think we have good data yet to predict who in front of us, sort of when they first become suicidal, what are the markers or indicators to figure out who will be a multiple attempter? I wish we were there yet, but we're not. What we do know is that it's the second we know someone's had 2 or more suicides, that gives us incredible knowledge and power to be able to act on. So, for example, if I'm running a primary care clinic or a hospital, you can bet, just like I want to know if you have a someone in your family, a first degree relative with a family history of a myocardial infarction, or for lung cancer or for breast cancer, I also want to know who are the people in my population who have 2 or more attempts. And I want to flag in that medical record so that I can appropriately deliver the best care, because I know what's happening with them, okay? And if you can't put a flag in the EHR, if you can't do that, at least make sure you're asking, okay? So we know that with multiple attempters, we don't need to ask about, if we had 5 attempts, we don't need to ask about all 5. We oftentimes will ask about the worst point episode and then the most recent one. So the worst point doesn't mean how sick they got or how damaged they were from the attempt. It means what's the most lethal means they used, because that tells us what they're capable of. Remember, if someone really, really, really wants to die, that doesn't mean they use a firearm, or if they kind of want to die, they take 5 Tylenol. Whatever people have at their disposal is what they tend to use in an attempt, okay? Also, your multiple attempters are not going to be great reporters of their symptoms. They're not great at predicting that they're about to lose their cool. They're not great at managing their impulsivity. They have sort of disinhibition, okay? And I don't believe there's any literature on executive functioning decrements or frontal lobe dysfunction in this particular group of patients, but it is something to be aware of. So instead of just asking them, so that 1 to 5 Likert scale is probably not great for your multiple attempters, okay? Remember, we just talked about asking them if they think they're gonna do it. This is your crowd, and again, very small percentage of patients. This is your crowd who's probably that's not gonna be very useful with. In fact, objective indicators of risk are often better. So do you have access to the means? Have you made detailed plans? Is someone likely to find you? Is someone likely to interrupt you? Do you have the opportunity to attempt? All right. And we talked about the survival reaction, post-attempt response, post-survival reaction as a good indicator of what's to come in the future. All right, here's your green screen. These are the different ways to ask the question. So put in the chat box, what's the first skill? What's the first step we're going to take for every patient every time? I want to discriminate between what? Put it in the chat box. Well done, Harry. So SI and DI, thank you. Thank you for that. Discriminate between SI and DI, good. And what's skill number 2? Put that in the chat box. We're assessing for prior history of skill number 2, prior attempts. Thank you, Julie. Prior attempts. Thank you, Sadie. So prior attempts and also behaviors. So if they've engaged in suicidal behavior somewhere. So what's a behavior? It's all the behaviors that precede an attempt, like planning, rehearsing, buying a firearm, looking in your medicine cabinet to figure out which pill should I take or which combination, taking out the alcohol and putting it next to the medicine cabinet, right? Those are all suicidal behaviors. They're antecedent behaviors that precede and are related to an attempt, okay? Someone's history of doing that, even if they never attempt, if they've done the behaviors in the past, they're highly likely to do them in the future. Okay, and again, just one more time here. If your patient has DI and 0 history of attempts and 0 history of behaviors, the assessment stops. You are done assessing, okay? Going back here. If you do steps 1 and 2 and they're both negative, you don't ask anything else, okay? And then you do address the DI. How are you coping with those thoughts of death? How are you just managing your stress? How are you coping with life? And that becomes the intervention. That doesn't mean they necessarily need a behavioral health referral. Certainly if you have behavioral health in-house, that's appropriate. But I've seen many skilled physicians, nurses, NPs, and PAs do a very brief coping intervention to say, hey, John, Sue, what's the best way you've learned to manage when you're overwhelmed? And are you doing that? And who is in your life who you can lean on for social support? And are you reaching out to them? Those are some of the best ways to manage those moments of DI, is just reassuring the patient. I also educate them. I say, hey, you know, that's actually more common than you'd think. So don't worry, you're not going to turn around and just kill yourself. Now, however, if it does grow into SI, please do call right away and do come in for a walk-in appointment. Here are the books I recommend. Again, I get no kickbacks for these or any kind of, there's no conflict of interest. This is specifically tailored for the primary care culture, especially those who have integrated behavioral health. This is more for mental health providers. It's the BCBT treatment manual. And this book, I believe, is still in pre-publication order status. You can get it on Amazon. This is more for system thinkers and people who really want to understand why we haven't bent the suicide curve in the last 30 to 50 years. As always, here are your resources, and I'll spend the last few minutes for questions. Thank you so much for your participation, guys, as usual. Been a pleasure working with you. And any questions?
Thank you so much, Dr. Corso. Please don't be shy. If there are any questions, go ahead and ask them. This has been so helpful and so informative. Please remember, we will have part 4 of our 6-week series next week, Tuesday, same time, 12 to 1.